This meeting is being recorded.
Well, welcome again, everyone. It's really nice to come back. I wasn't here on Tuesday, and I saw you all on Saturday, or almost all of you on Saturday. And I was hoping if anybody had any opportunity to experience or I guess practice using Rule of Six, if you wanted to maybe just shout out your experience in case anybody had that over the weekend or beyond. Does anybody have anything like that they want to share?
I actually brought it to, I brought it to my team meeting at work this week, and I had the other case managers kind of talk about it. So
awesome. So not necessarily experiencing it in real time, but still being able to talk about it with other folks and kind of letting them know.
We talked about it with specific individual.
Oh, awesome. Okay. So you were able to practice it. That's great. Thanks. Did it seem helpful?
It was very helpful.
Oh, good. That's good to hear. Great. Well, again, welcome back, everyone. Thanks for making it to the third of 5 time points in this training series. Today, we are going to be talking about our services in the mental and chemical health department, and a little bit more information on de-escalating, clients that might be in crisis. And with us today is one of our favorite mental health therapists, Laura Colladoro. We invite her time and time again to lead these presentations, and I think you will all enjoy hearing from her too. Laura, do you want to introduce yourself a little bit more and tell them kind of about your history at Tubman?
Yes. Yeah. Thanks, Katie. Yeah. These guys are always just pumping up my ego in these trainings. So hopefully I can try to live up to the hype. Yeah, my name is Laura. I use she, her pronouns. I am a mental health therapist with Tubman. I work primarily out of the Chrysalis Center, and then also doing a lot of telehealth right now still too. So I also the clinical intern program coordinator. So I do a lot of work with our clinical and case management interns. And I have done, I think at some point since I've been with Tubman, I've done spent time in almost all of our groups in some capacity. And then I work with individual clients. So I'm going to talk through what some of those services and programs are. And if you have any questions about them, hopefully I can answer any of those questions since I'm fairly familiar. So feel free to ask questions throughout the presentation. Hopefully we'll have a little bit of time at the end too for questions, but don't hesitate to throw something in the chat or just pop off mute and ask a question if you have it. So yeah, all right, let's go ahead and get going. So we're going to start with talking about what some of the specific services that we offer for mental and chemical health. So we have quite a few, we have about 12 to 15 mental health therapists. And then we almost always have clinical interns who can do individual therapy as well. So we work with a lot of clients individually. We're a community mental health center, the Chrysalis Center. So we can work with clients who are staying in the shelters and using other Tubman services. But also a lot of clients just come in who have found us either through their insurance or they've been referred by another provider or something like that. So we can really work with clients just coming in from the community. We can work with clients of all genders, and we can work with clients across the lifespan. We don't really have many therapists right now who do a lot of work with kids. And we also just don't get a lot of kids seeking therapy, just kind of calling in. But we do on occasion. So we can work with all ages, all genders, and we get clients with a lot of different presenting concerns seeking individual therapy, along with some of the other services that we offer. We have some therapists who see couples, and sometimes we get couples coming in seeking therapy, families as well, seeking family therapy. We also have clinicians who can do chemical health assessments. So clients who are seeking co-occurring disorders treatment or treatment for chemical dependency and mental health, simultaneously seeking a treatment program. And they can come in and get a chemical health assessment, and they could, if they're a good fit for our chemical health program, our co-occurring disorders program, they could end up getting referred to our program through that chemical health assessment, or one of our LADCs, licensed alcohol and drug counselors, might refer them to another treatment program within the community after that assessment. So we do have that service as well. We have a trauma skills group, which is a group that provides a lot of psychoeducation and skills specifically to help manage trauma-related symptoms. And so that is about a 13-week-long group that clients can sign up for, and it's a closed group, meaning that all of the clients who are waiting to start that group started on the same day and complete that group together, and then end that group together at that 13-week mark. And then a new set of clients can start. We have previously had a trauma process group that has been on hold for a while just because we haven't had as many clients seeking it out, but hopefully it's something that we'll be able to start back up again at some point. We also have this group called Melissa's Connections group. And I always like to highlight this as just one to flag because it's kind of unique. The Melissa's Connections group is a grant funded group. And so clients don't need insurance to do it. They don't need to pay anything out of pocket. It's completely free. If clients don't have insurance, it's no issue. And it's also just a drop-in group. They don't have to register. They don't have to commit to a certain amount of time. They just call intake, let them know that they're seeking that out, and then intake can give them the information. That one has also been being held virtually as of late, but it's something that at some point will likely go back in person. But for now, it's virtual, and so if a client calls intake can provide the Zoom information for clients to go ahead and drop into that group whenever they need it. And it's for clients of all genders and for anyone struggling with anything related to mental health, chemical health, or both. I'm just going to look at this question in the chat. Does the trauma skills group happen at TEM and Chrysalis or virtual? Currently, the trauma skills group is in person and it's held over at the Chrysalis Center. So that is on Thursday afternoons from 4 to 6 afternoons, early evenings from 4 to 6 p.m. over at the Chrysalis Center. Yeah. The groups are a little bit of a mixed bag right now as far as what is happening in person and what is happening virtually, because we're just kind of trying to balance things as best we can based on need, based on interest, and based on accessibility. So the groups are probably about half and half right now as far as virtual and in person. All right, so a couple of other programs that we have. So all of the programs here on this list have multiple groups within each of these programs. So we have a program called the Relationship Violence Intervention Program, and that is a program. It's 21 weeks long, so it's about 5 months, and that group involves a lot of psychoeducation on healthy relationships, psychoeducation on various forms of abuse and violence and intimate partner violence. And a lot of the clients in this group, not all of them, but many of them are referred by probation or CPS, and they're required to do a group like this. And so that's where we get a fair number of our referrals for that group, but anyone can self-refer to that group as well. And we do usually at any given time have a couple of clients who have self-referred to that program, either because they have experienced some kind of violence or abuse, or they have themselves engaged in some kind of abusive behavior and are looking for additional education and skills to help be able to manage difficult interpersonal situations more effectively. So that's a little bit on that program. And we have a state certified DBT program, or dialectical behavior therapy. So the DBT also is a very skills heavy group. Anyone who's in the DBT program has their skills group once a week, and then they would also see an individual therapist and do an individual DBT session once a week as well. And so the group really focuses on the skills, and we teach the skills, and those skills are mindfulness skills, interpersonal effectiveness skills, so just some healthy relationship and communication skills, a lot of stuff on boundaries and things like that, and then a lot of emotion regulation and distress tolerance skills. So those are the 4 content areas of DBT. So really anyone struggling with managing relationships and or regulating their emotions. Those tend to be some of the things that people are struggling with when they seek out DBT. And so again, same thing with the DBT program. We have multiple different groups. We have a Tuesday evening group, a Thursday morning group, and then we actually have a queer specific DBT group that meets on Tuesday afternoons. So a few different options for people to figure out what's the best fit for them. And then we also have a co-occurring and intensive outpatient co-occurring disorders program. So this program is for women identified clients, and it's intensive outpatient. Our intensive outpatient program consists of programming 4 to 5 days a week. So in the COD program, we've got groups that a group that meets on Monday, one that meets on Tuesday, one on Wednesday, and one on Thursday. And then in addition to that, all clients in that program also meet with an individual mental health counselor once a week and an individual chemical health counselor once a week. So it ends up being about 10 to 12 hours of programming every week. So it is fairly intensive. And again, that's for women who are struggling with mental health and chemical health.
I'm going to ask you to pause just for a second. Laura, if anybody has any questions, stick them in the chat or ask. Oh, never mind. Katie was just having trouble identifying some of you, but if you're the name on your little screen doesn't identify you because we want to track that you're here, change your name. Sounds like most of you have done that, but if there's any question, please do it. Okay. Sorry, Laura.
That's all right. So that's a lot of information. It's a lot of words from me. There are program guides that you may already even have, I think, and just keep those program guides handy, because that's a lot for me to even keep track of, as I say, and I'm like involved in these groups all the time. So keep your program guides handy because it has all of that information that I just talked about and more. So if you ever if you ever have a client has a question that you want to try to answer, just take a look at that program guide and see if the information that you need is in there. So, and you're also welcome to, just reach out to someone, reach out to Intake. They're fabulous. They know all about all of the programs. And they're also the one-stop shop for clients to get signed up or connected to any of these services. So that's also on your program guide. Clients can just call the intake department and let them know what program or group or service they're interested in, and then Intake can help them coordinate it from there. All right, so we're going to shift gears a little bit from talking about specific services and programs to talking about some definitions, some terms that are really relevant to a lot of the clients that we work with. And I think that I'm going to answer this question actually quick first. The program guide mentions that a number of groups are on pause. Is there a timeline for when programming is hopefully? It would depend on which group specifically. I would be able to maybe give a clearer answer for that, but off the top of my head, when I think about the programs that are currently on pause, I don't think that we have a specific timeline right now, because it's really just based on need and interest. And so if we don't have clients calling in, seeking out those groups, then we're not going to plan to restart them. So as of right now, I don't think so. There's not a specific group that I can think of that is on hold that we have a timeline for when that group would return. All right. So let's talk about mental health. It's a term that I think gets talked about a lot, probably even a lot more nowadays. And I think there are a lot of different ways that we can define mental health. So let's talk about that as a group and see if we can kind of come up with a sound working definition of what we mean when we say mental health. So what do you all think of? Feel free to, just shout something out or put something in the chat if you're more comfortable that way. What comes to mind when you think about the term mental health or hear that term? All right, I'm going to read these off as they're coming in. Emotional well-being, stability, how one feels and thinks, stress, anxiety management, psychological, able to handle emotions. Yeah, absolutely. Sense of safety, having capacity. Yep. Yeah, absolutely. A lot of the, I think everything actually in here relates to mental health, and I think goes into how we define, how we look at, how we assess mental health. So yeah, our well-being, our emotional, someone just said emotional, social, and psychological well-being. Yeah, there's kind of this, like, there are these different layers, right? And these different facets to mental health, different areas of our functioning. So someone said having capacity, being able to handle our emotions. That's a big thing that we look at when we're considering mental health or assessing mental health, is how are we functioning? How is someone functioning, in their relationships, at work, in their daily life, being able to take care of themselves. And then in addition, I think, a few people mentioned emotion, stress, anxiety. So another big thing that we look at in addition to functioning when assessing and considering mental health is really just generally how someone is feeling, right? On kind of a, not just moment to moment, but over a period of time too. Is someone experiencing a lot of distress? So if you actually look in the DSM, the manual that has different psychological disorders, mental health disorders in there, every single one has this kind of these couple of components in common, right? It lists out the different symptoms that are unique to that particular diagnosis, but then what they all share in common is, are these symptoms impacting the person's functioning, and are these symptoms causing the person distress? So those are things that we really look at when thinking about how is someone doing, right? How is someone's mental health doing? And I think a lot of you really hit the nail on the head, right? With, how are they coping? What kind of emotions are they experiencing? Are they able to manage those emotions? How are there different areas of well-being and functioning in their life? So those are some of the different aspects of mental health. What if we do the same? Let's do the same thing for chemical health. What comes to mind? Same thing. Go ahead and shout stuff out or put something in the chat. What comes to mind when you think of the term chemical health? Trying to cope, how prone someone is to addiction, substance use or sobriety, relating to substance use disorder services, your body, mind, and spirit are balanced, that triangle, yeah. A person's relationship with substances, yeah. I think that's a really nice, it's short and sweet and concise, and I think that really is a nice definition of chemical health, a person's relationship with substances, right? Because maybe someone has right, a really healthy relationship with substances, or maybe someone has a relationship with substances that is causing different problems for them, having different negative consequences, negatively impacting their health, things like that. Self-medicating, yeah, a person's, and that makes me think about someone earlier said trying to cope or an attempt to cope. Yeah, so self-medication. A person's relationship with mind-altering substances, absolutely. Dependence and how substance use affects behavior. Yeah. Yep, these are all related to chemical health, and I think these are all things that we consider and look at and assess for when we are kind of assessing someone's chemical health. So yes, what's their relationship like with substances? Is their use? Are they sober? Are they in recovery? Are they abusing substances on occasion? Is there an ongoing dependency on substances? One of the things that we look at when or something that can be an indicator of some level of dependence is continued use despite negative consequences. That's kind of a key phrase that we use a lot, and that can give a lot of information, right? If someone's relationship with substances is having negative consequences for them and continues to have negative consequences for them in their life, and they are continuing to use those substances, then that can be an indicator that there is some level of dependence on those substances. So yes, nice. Really appreciate everyone's contributions here. I think together that gives us a really nice working definition of chemical health. Let's shift and talk a little bit about trauma. So trauma, I think we use that word, and that word gets used in a couple of different ways. So sometimes when someone uses the word trauma, they might be referring to a traumatic event, right? Like the actual traumatic event or events. And then other times, I think when we use the word trauma, we're using it in a little bit broader way, where we are referring not only to the traumatic event, but also how that trauma or that traumatic event or events continues to impact someone long term. And I think that is, yes, understanding what the trauma or the traumatic event was is really important. And I think when we look at what really makes something traumatic, it is the fact that, that experience or those experiences are having a significant long-term impact on the person long after the event or events are actually over. So I think that's something important to keep in mind. And part of the reason that I say that too is because that's sort of how we're going to talk about trauma for the remainder of this presentation. So we're going to talk a little bit about how trauma impacts the brain, and that's a really big part of that long-term impact, right? That trauma really alters many different aspects of how we function, how our brain functions, how we interact with the world, and how we interpret and organize different experiences moving forward. So, and one other thing about that is that another term that I think gets used a lot, more so now than ever, is trauma-informed care. And that is something that we really strive for within the Tubman organization, because so many of our clients, I mean, if not all, so many of our clients have experienced some form of trauma. And because trauma does impact us in so many ways long term, it makes it very important that we have some knowledge and understanding about how trauma impacts people, how it can shape behavior, how it impacts functioning, and how we interact with other people. And so that is something important to keep in mind, is how can you take some of the information from this presentation and really integrate it into your understanding of people and of some of the clients that you're going to work with, so that you can use that information to think about and work with clients more effectively. So this next slide is a graphic, an image that can be pretty helpful. It's not perfect, and it's simplified way down. The brain is, of course, far more complex than this, but I think this model can be really helpful for starting to understand how trauma impacts the brain long term, right? And how, when someone has experienced trauma, how that might make the way that they react to or respond to an event or an interaction in the future more or just different, how it might make the way that they respond different because of that trauma history. So this image breaks the brain down into 3 different parts. So you've got kind of that smallest layer in the center, and that is, if you look at the top of the content, the first bullet point, the brain stem, or the reptile brain, or the survival brain, we can also call it, that's referring to that smallest section, that white section, that innermost layer. So that's our brain stem, right? It's kind of in the back, down on the inside, way at the bottom. So that's our brain stem. That is the least evolved part of our brain. That's partly why it's nicknamed the reptile brain, because reptiles, that's their whole brain. And so I think it can be helpful to think about that nickname, because it gives us information on what that part of our brain does. So if you think about, well, what capacities do reptiles have, right? So if that's their whole brain, what capacities do reptile brains have? Survival, right? Getting their basic needs met, involuntary organ function in order to stay alive, right? Impulses, instinct, survival impulses, right? Defensive responses when there's a threat. So that's exactly what our brainstem does. All of those same things. Helps with involuntary organ function, survival, our basic needs, right? Those are all of the capacities that are all kind of hardwired into our brainstem. So that's the first section, right? Then if we kind of work up and out, kind of down in here, we've got in the midbrain, there's a cluster of structures known as the limbic system. Another nickname for the limbic system is the mammal brain. So same thing, if we move on from reptiles, right, and we think about mammals, right, if anyone has a dog or a cat, or if you think about like primates and dolphins, and what capacities do those animals have that, in addition to what reptiles have, what capacities do those animals have that reptiles don't? Well, they can connect, right? They have attachments, they have relationships, they have social communities and social hierarchies. They also have memory, and they have emotion, right? And not just fear, right? Because fear is survival-based emotion, but they have other emotions too. So that's our midbrain, that's our limbic system, right? Gives us all of those same capacities, right? The capacity for emotion, the capacity for memory, and connection and attachment in relationships. Okay. So I'm describing these first, and then we'll talk about how they relate and interact specifically as it relates to trauma. So then if we keep moving, right, the brain continues to evolve, and then we as humans have parts of the brain that no other animals do, specifically the cortex and the prefrontal cortex, so kind of the outermost and frontmost parts of the brain. So we can nickname that the human brain, or our reasoning brain or our thinking brain, because our prefrontal cortex, the capacities that gives us that other animals don't have, are higher level executive functioning, right? Meaning making, higher level self-awareness, right? Making judgments and drawing conclusions, things like that, right? Weighing out different variables and options in order to make sound decisions, things like that, right? So, excuse me. So when we take all this information and we think about, okay, well, how does trauma relate to this? When someone experiences something traumatic, it overwhelms the brain, right? And the brainstem kicks in, the fight or flight system, right? The defensive action system, which is that survival brain. When that happens, it actually changes the way in which our brain functions, and it causes our brain to be predisposed to going through that process again. Our brain becomes wired toward threat, right? So we are more likely, if someone has experienced trauma, they are more likely to perceive something as threatening or dangerous, even if it's actually not. And if we perceive something as threatening or dangerous, right, our prefrontal cortex takes in information, right, draws a conclusion about it, and an alarm bell goes off in the limbic system, right? And that sends a message to the rest of the brain saying, you know, alert, danger, right? It's like it sounds an alarm. The prefrontal cortex starts to shut down, right? And blood flow gets diverted to the brainstem, right? Because that's the brainstem's job, right? Is to protect us. That's our survival brain. So when someone has experienced trauma, their brain is more likely to more often and more quickly go through that process, right? Alarm, alarm, danger, danger. Prefrontal cortex shut down. The reason for that is the prefrontal cortex is too slow, right? It's really useful. It gives us a lot of really, really helpful abilities. But in a threatening situation, or a situation that is not threatening, but that we have perceived to be threatening, that we don't want to use the prefrontal cortex, right? Because it weighs out too many variables. It considers too many things, right? Again, weighing out options to try to make a sound decision. But if something bad is happening, right? If we're with a little kid and they, go and reach to try to touch something hot, we don't want to, slow down and think about that and think about, how much time do we have, and, should we, how should we stop? We just act, right? Or if we go to walk across the street and all of a sudden a car is coming around the corner, same thing. We don't have time to break it down and really weigh it out. We just act. Our survival brain kicks in and we just act, right? So that's really useful and helpful in a lot of ways. But when someone has experienced trauma and their brain is hardwired, right, to seek out and find and a lot of times even perceive something, again, as dangerous or threatening that might not actually be, well, then the prefrontal cortex is shutting down and they're going into their survival brain and potentially acting out in some way, fight, flight, right? So lashing out or, running away, trying to escape, storming out, rather than seeing a situation through, right? behaviors that can be really challenging if we're on the other end of it, right? And if we're not actually, right, if there's not actually a threat, right? But I think that's why I appreciate the last bullet point on this slide so much. Behavior isn't on purpose, behavior is for a purpose, right? Because, right, for a traumatized brain, that the brain is seeking safety, right? The brain is trying to avoid danger or overwhelm or get away from those things, right? So it can show up as really challenging behaviors, but I think when we have this context and this understanding, and we can recognize, okay, this person is likely not operating with their prefrontal cortex, right? Which means they're not able to see the whole situation, right? But instead are reacting out of overwhelm or fear, then those behaviors can start to make a lot more sense. Right? And we'll talk a little bit more further into the presentation about how there are different ways that we can show up and interact differently to try to de-escalate some of that overwhelm, to engage in ways that are as least threatening as we can be. So I'll pause here in case there are any questions. All right, we'll keep going. Okay, so let's talk a little bit about, we're going to talk about a handful of different skills here. We're going to start with just kind of general skills that are helpful in most client interactions, and then we'll talk specifically about some crisis and de-escalation skills. Okay. Someone asked, how does trauma impair memory? That's a good question with I think a really long answer, probably more than I could definitely more than I could fully cover here, but trauma can impact memory in a lot of different ways. Because when someone experiences a traumatic incident, parts of their brain shut down. That can make it so that as it relates specifically to the traumatic event, there can be a lot of gaps in memory. Trauma also expands our capacity, strengthens our capacity for dissociation or checking out and being not being present or as present in any given moment. So that's another big way that trauma can impact memory, is if it strengthens our capacity for dissociation, makes us more prone to dissociation, causes us to dissociate to some degree more often. Well, then those moments in which we were dissociated, we're not going to have, as you know, we might have slight gaps or even just like fuzzy memories there. So trauma, and I see this with my clients a lot of my clients do really struggle with memory. They're more forgetful. It's harder to track things. So yeah, trauma can impair memory and just make it so that there are different gaps or just areas that are not as clear and easily retained. So that's the short version, but hopefully it gives at least a little bit of information on that. Yeah. All right. So some helpful skills for interacting with clients. Active listening. I know this one might feel really basic, but it very well might be the most important, right? When we're interacting with a client, whether we're interacting with them in person or we're on the phone, anything that we can do to communicate to them that we are actively listening, we are present with them, whether that's eye contact, right? If we're in person, eye contact, nodding along. If we're not in person, if you're interacting with a client over the phone, there's a kind of a tool called minimal encouragers, which are just kind of like, it always sounds so silly when I do it in a context like this, but it's just anything that's like, yeah, yeah, okay, okay, right. So sounds goofy right now, but when it's in context, right, you're on the phone with someone and just every once in a while, right, like saying something small like that to let them, right, it's not just, complete silence on the other end of the phone. That can be an active listening tool for phone contact. Asking open-ended questions and really giving the client time and space to talk, just holding space truly, and giving some of those nonverbals, or kind of small paraverbals that let the client know, I'm here, I'm with you, I'm listening. It really goes a long way. I mean, the reality is for some of our clients, they really don't have very many people in their lives who do that for them, and so it can really go a long way in establishing some rapport and creating a sense of safety. So active listening, again, I know it's probably sounds simple and obvious, but again, might really be one of the most important things that we can do for our clients. The second one, contact statements, that phrase might be a little bit more unfamiliar. It actually comes from sensory motor psychotherapy, which is a trauma body-oriented talk therapy for trauma. So the idea with a contact statement is that it's a they typically are relatively short and sweet, and it's a statement that makes contact with the client's experience. So whether that's something that they've said, whether that is an emotion that it seems like they might be experiencing, or that they have said that they're experiencing, or maybe it's some kind of physical experience, making a statement that touches on that acknowledges it, or points it out in a really gentle way. That's a contact statement. And those can be really powerful because, like active listening, but I think sometimes in an even more deeply felt way, contact statements make us feel heard and seen, right? So if a client is, let's even say, I know there are quite a few of you that are going to be working with kids in the shelter. So let's say you're working with a kiddo and some kind of situation happened that was upsetting to them and they're getting a little bit worked up, right? Contact statements with kids are equally powerful. So we might, you might just make a brief contact statement that could be as simple as, it seems like you're really upset, right? Or it seemed like that really bothered you. And even that language of it seemed like, I use that a lot with my adult clients too. Using language that is just a little bit tentative, I think is helpful with these contact statements, because sometimes we do miss the mark, right? Even if it really does seem like something, right? Sometimes we don't get it exactly right, or maybe the word that we end up using, or the emotion that we end up using, is maybe just not exactly what they're experiencing, right? So maybe you're talking with a client and you're kind of trying to read between the lines of what they're saying, and you say something like, it sounds like you're really frustrated by this. And maybe they say, and just having that tentative language, I think, opens it up for them to correct us if needed. And so maybe they say, I don't actually know if it's so much that I'm frustrated. I was just really disappointed, right? Or something like that, right? So a contact statement, right? Trying to make contact with something that the client is experiencing, something that they've said, something that it seems like they're feeling. Maybe it's like their breathing has changed, or, oh, I noticed that when you started talking about that, your voice got, your breathing changed, and your voice even got a little bit quieter, right? So just kind of gently pointing something out in a way where we're trying to convey, like, I'm hearing you. right? That's a context statement. And then we've got reflection. And reflection can be similar, but I think the difference is with reflecting back, we're not really trying so much to kind of like read between the lines, or it's more of just actually reflecting back, right? Maybe paraphrasing something that the client has said, or maybe they kind of just talk to us about a handful of things and we just want to reflect back to let them know, again, A, I'm hearing you, and B, let me check it out and make sure that I'm tracking everything, right? Okay, so you mentioned this and you talked about this, and then there's this thing too, right? So maybe we just reflect back to make sure that we're getting everything and not missing something. All right, so we've got a few more here on the next slide. Validate, that might be another one. Maybe it's familiar to some, maybe not. But let's actually throw this one out. I'm talking a lot. So what do you all think of? Even if we can just get a couple of responses, what does it mean to validate? What do you think of when you hear that word? What is validation? Being empathetic, to allow
Positive feedback.
Did you say positive feedback?
Yep. Mm-hmm.
Yeah, yep. Positive feedback can be very validating. Absolutely. Reaffirming, to allow someone to feel how they feel. Nice. Yep. Yep. I think that one really describes and defines validation well at its core, right? Allow someone to feel how they feel and acknowledge and affirm. Yes. Not minimize, to not minimize or dismiss. Absolutely. Normalizing. Yep. I think normalizing is a form of validation. Recognizing someone's feelings. Yep. Frame it differently, maybe. I guess I might just have to think about that one a little bit more. I think depending on how we frame something differently, maybe we reframe something in a more validating way. To confirm an emotion or experience makes some sort of sense. Absolutely. Yep. Making someone feel heard in their feelings, affirmations that a person's feelings and opinions are worth it. Yeah. Yep. You all got it. These are all very, very good descriptors of validation. Letting someone know, like, I hear you. I'm hearing what you're saying. You're feeling. Your feelings are valid. They make sense. They're worthy. They matter, and you matter. Your experience matters. Yeah. Question in the chat. Can you speak a little on what validation looks like when someone is experiencing suicidal ideation? That's a good question. And I think that validation validation at its core is still going to be the same. And I think that, processing this in real time, I think depending on, a conversation about suicidal ideation can look so many different ways and sound so many different ways, right? The person can be saying a lot of different things. And I think that depending on what exactly that conversation is looking and sounding like, we might need to be a little bit careful with validation in that situation, because we don't want to try to go to validation I'm almost thinking about kind of like toxic positivity, right? Like I think we'd want to be careful not to use validation when someone is talking about something like suicidal ideation in a way that actually might invalidate what they're saying or what they're experiencing. So that's one thought that comes up for me. And then another thought that comes up for me is that some of the things that someone might be saying when they are experiencing suicidal ideation might be things that we maybe actually don't want to validate, right? Because the way that people can be seeing things and interpreting things when they're in that state might be clouded, right? Might be really clouded by the level of distress that they're in or the level of depression that they are experiencing, right? So if they're saying things like, well, everything is hopeless, or no one cares about me, no one would care if I'm not here, those are the kinds of things that I'm thinking of when I say we would want to be careful to not validate those statements. We can validate, and that speaks to kind of what's under the bullet point here for validation, being careful not to validate or join something that isn't actually valid. And I think a helpful way to think about that as it relates to this question is we can validate the pain, we can validate the emotion, we can validate the experience, right? Without necessarily validating the specific thought or belief, right? So even a way to, and I think we would want to have a relationship with the person to kind of know if this is something that they can receive. But in a situation like that, right, we can validate that it really feels that way, right? That's even something that we could say, like, this is like, you're in a lot of pain right now, right? That feels really painful, that it feels like no one would care, right? That must be really painful. Without saying, yeah, that makes so much sense, right? Yeah, no one would, right? We don't want to validate those thoughts or beliefs that might not actually be true and could actually serve to just increase the distress or the suicidal ideation. Okay. If there's more on that, go ahead and speak up or put it in the chat. But yeah, I think it's just a conversation like that can just be, it takes so many different forms and shapes. And so if there's a more specific question about that, maybe it can be passed along to me or asked at the end or something like that. So, okay. A couple of more helpful skills. A lot of what we've talked about really goes into this, but be present, right? We've talked about some different skills to really kind of show and convey that we are present. And we've talked about some skills that you really can actually only use if you are present, like a contact statement. I think in order to even make a contact statement, you have to be present. You have to be paying attention in order to make a gentle comment about something that you're noticing. But yeah, just really, really keeping your focus in the here and now. Some of the active listening stuff, I think we all know what that looks like. And so, if we wanted to, we actually probably could fake it. But at some point, the client's probably going to notice, right? So not only trying to show that we're listening and that we're present, but really actually being as present as we can. And we're all human, right? Like, our minds are going to wander sometimes, or we're going to be distracted by something, but just as best as we can, really actually truly being present with the client. And then this last one, be curious about underlying needs. This goes, I think, along a little bit with the context statements, right? Where we're saying, listen to what is being said and see if it feels like there's, a fairly clear conclusion that you draw or something that you're noticing in what is being said. So maybe a client is talking about something and you realize, it seems like there's a theme here. Like there's a theme in what the client is talking about and something that is missing or something that they're not getting. Whether that is connection or stability is the other one listed here. Maybe they are, maybe they're just talking about some different situations that they've been experiencing recently. And it sounds like they're just feeling really hopeless, right? So that might be an underlying need, is to feel more of a sense of hope. So that's just another, I think, kind of lens through which we can listen to what a client is saying, you know, just see if you can notice if it seems like there's a theme or something that the client might be needing. And then you can check it out with them, right? You don't have to assume. You could just say, you know, it's not based on what you're saying, it sounds like maybe this is missing. Is that something that we could work on? All right. So let's talk about crisis situations a little bit. So we've got a poll here. So let's go ahead and just do it, and then I'll talk a little bit about kind of context, and hopefully it'll make a little bit more sense why we do it. What comes up for you when you think about being in a high intensity or crisis situation with a client? And I think you can check more than one. So go ahead and check all that apply for you. And then we'll see where we land as a group.
Laura, we do have at least one person who's in a car driving. Just realized at some point, just read all the answers. If not now, in case they're not seeing the screen.
Looks like we're just waiting for a couple more.
Okay. All right. Okay, so this is pretty typical that we get like a pretty good spread of answers, and a fair number of people who endorse a lot of the different responses. So some of the different options, I don't know if I have the tools to handle that. 24%, I feel nervous, 62%, so over half. I might feel threatened or unsafe, 24% there, still a good amount. Will I have help if I need it? Also a lot of people thinking that. And then I feel mostly confident in responding, 41%. So a pretty good mix. And that's, you know, I think part of why I like to do this poll is because I think it's helpful to, it's a little bit validating, speaking of validation, to see that, oh, okay, I'm not the only one who feels this way, right? When thinking about a crisis situation, right? I always answer the poll too, because it comes up for me. And, you know, I've dealt with a lot of different crisis situations with clients, and I still, when I think about it or when I go to approach it, I feel a little bit nervous. I think that's totally normal. You know, some of those other responses we're gonna speak to a little bit, right? Like the nervousness, or right, the response of, will I have the tools? Do I have the tools that I need to handle that? We're gonna talk about some tools tonight, so hopefully that you know, maybe increases at least a little bit of confidence in that regard of, okay, I have some tools, I have some things that I can fall back on as far as how I can approach this. Will I have help if I need it? We're going to talk a little bit about that and how it's really important to get, you know, if it's available, and hopefully it always is in some form, that it's totally okay to seek out help. And I think it's always better to have, you know, an extra person on hand when dealing with a difficult situation. So we're going to speak to some of these things, and hopefully just seeing that poll helps everyone realize that a lot of us share these different thoughts and feelings that come up around crisis situations, because they're intense, they're challenging. So let's talk about some skills. So the last group of skills that we just talked about, those were kind of those were in no particular order. We kind of use all of those, you know, just sort of on an ongoing basis. These skills are actually put in this order for a reason. I think it is kind of helpful to think about them chronologically in this way. It's not going to be perfect. It's not going to be exact. And, we might have to kind of return to one at a later time. But I do think that it's helpful to think about them in this order to some degree. So when we realize there's a crisis situation happening that might require some de-escalation, I think a really good place to start is with ourselves, right? And just like in that poll just now, a lot of people, there were a lot of responses around like, I feel nervous when I think about that, right? So if we are, right, if we're on site or maybe we're on the phone and someone starts to kind of escalate in any situation like that, it's normal to have a response, right? To get nervous, to maybe have a physical response, right? Some physical anxiety. And so checking in with ourselves right away, okay, how am I doing? What am I noticing, right? Like, how's my heart rate? What's happening in my body? And then doing a little bit of grounding for ourselves, right? However, even if it's a very small amount of time that we have, if we can just take a few deep breaths, right? Or do some kind of, maybe we have like a really accessible like self-soothing technique. Maybe it's just making contact with ourselves can be soothing. So maybe you put your hand on your chest and take a couple of deep breaths. Maybe you clasp your hands together for a minute, right? Maybe you kind of put your hand on your neck or something. Those things can be grounding and soothing and help us to regulate a little bit before we go into this situation where part of our job is going to be to try to help someone else regulate, right? So that has to start with ourselves. So some kind of grounding, self-soothing, pushing your feet into the floor can be another helpful one. Anything like that. Take a couple deep breaths. Start with ourselves, right? And then when we go and we approach the situation or we approach the client, we want to be really mindful about our nonverbal communication. And just the way that we are approaching, what we are conveying with our body language, with our tone, right? So we want to use a really calm and gentle voice. Be really mindful of our volume. Even if the client is loud, we don't want to get loud too, to talk over them. Sometimes that's kind of a natural instinct, sort of an automatic instinct, is, oh, I have to be louder so they can hear me. But actually that can just serve to escalate them more, because it can be perceived as threatening, or then they might feel like, well, they're not going to hear me because they're being loud, so now I have to be even louder, right? And then we kind of just keep climbing, right? Which is the opposite of what we want to do. So actually using a quieter voice typically has kind of pulls the client down, right? So being aware of your volume, being aware of your tone, being aware of your posture and your placement. If you're in person with someone, be aware of where the door is, where the client is, and where you are, right? And if it's possible to come in, you're probably going to come in the door, but then if possible, can you kind of keep going so that you're not blocking the exit, right? That tends to be really helpful. Again, right, they're in their survival brain now, chances are, right, if they're escalated, their brainstem, right? So they're in fight or flight, right? Well, if all of a sudden flight is, right, when we're in fight or flight, feeling trapped, right, and not having that flight option if we need and want it, that can actually just dysregulate us even more, right? So being mindful to not block an exit is really helpful. And be on their level, right? So if the client is sitting, we want to be sitting, right? We don't want to be standing over them, because again, right, I mean, just on a sensory level, that's more intimidating, right? That's more threatening if someone is standing over us. If we're working with kids, right? Kids are short, a lot of times shorter than us, right? So can we kneel down and get on their level, right? So they don't same thing feel someone towering over them when they're already upset and potentially in fight or flight. So being really aware of those nonverbals and paraverbals. And then we want to focus on, right? We started with focus on our own regulation. Then we want to turn our focus to the client's regulation, right? And really the main focus there is that, like, that's where we want to meet them, right? We don't want to jump to problem solving right away, right? Chances are they might not even, probably can't even do that yet, right? Their prefrontal cortex is likely offline. So right now it's just about trying to get more of the brain back online, trying to help them regulate, right? Trying to help reduce some of that distress, right? So even asking the client the very simple question, is there anything that we can do to help you feel just a little bit better right now, right in this moment? Anything that you think might just help you feel a little calmer, giving options, right? Because again, if prefrontal cortex is offline, it might be hard to even think about answers to that question. So if we can give some options, that's helpful, right? Can I get you a glass of water? Do you want to step outside? Would it be helpful if we went for a little walk, right? Just giving some options like that. And even those things, right? They're simple, they're basic, they can be helpful for self-soothing. And just reducing some of that distress, right? So yeah, just focusing on regulation, right? Starting there, whatever we'll worry about the rest in a minute, but for now it's just, can we help to bring them down a little bit? Is there anything that you need? Is there anything you think might be helpful? Is there anything I can do here? Right, and asking those questions, maybe not like rapid fire, right? I'm saying multiple to kind of give some ideas and suggestions, but we also don't want to rapid fire questions at them. It would be maybe asking one of those questions and then just giving some space. Right. All right. So once some of the distress has reduced some, I'm going to pause for this question. What do you do if you feel unsafe? If you feel unsafe, this is where it's really, if there's a way to get help, if there's anyone else there, if you can call your supervisor, anything like that, because that might help you, right? So now we can kind of go back, okay, now I'm starting to feel unsafe, right? Think about that brain image, right? So, we're likely going to want to respond in some of the same ways, right? Fight, flight. There's some other defensive action responses, and one of them is called attachment cry, which essentially means seeking support. So that's really probably, if you're feeling unsafe, that's probably the best thing that you can do in a crisis situation. And if the situation is, if it's escalated to the point where it does feel like there's some threat to you, you can also step out, right? You can tap out, whether that's you try to get help or you just step out, right? So yeah, we have to be mindful of our own limits too. And it is okay to, I mean, if there is genuinely a threat to your safety, it's okay for you to do what you need to do to keep yourself safe. But yes, definitely, I think one of the most important things is see if you can get some support, see if there's someone that can help in that situation. So that's going to be something, see if you can, when you're starting out, if you're meeting with your supervisor, or maybe it's in a breakout session, that's a good kind of question to make sure that you have answered from the get-go is, who do I contact and when, if I'm out of my depth, or if I have a safety concern or something like that. Just make sure that you know who your point people are and how to reach them. Yeah. Good question. All right. So then we might try to move to helping the client identify some existing skills and resources. So that can be as it pertains to helping them regulate in the moment, right? So we might ask them, you know, when you have felt like this in the past, what helps, right? What do you do? We could also use that same kind of approach or question if and when we do move into trying to problem solve whatever the situation is that led to the escalation in the first place, right? So if we get to a place where that seems appropriate, right? They're feeling more calm and are in more of a space to do that. We could ask that question too, like, okay, so this is the situation when you've been in a challenging situation like this, or have you ever encountered something similar to this before? What did you do? What was helpful, right? What supports do you have, or what resources do you have? And if you don't really have a lot, then maybe that's a place for us to start, right? We talked about this a little bit, but know your limits and continue to assess the situation, right? Get help if you need it. Right? This one we probably actually could move a little bit earlier in the list. I think if we're thinking about this chronologically, this is one that I think we want to sort of continue to check in with throughout the situation, right? And then be aware of what you bring into the room. That one I think is more kind of like an umbrella, right? Like that should sort of ideally be in our awareness to some degree, you know, throughout a situation and in most situations, not just crisis situations. But you know, what do I bring in the room with me in terms of my different identities, right? What does a client see when they look at me? What are the client's identities, right? Is this a client where you know, they might be having experiences that I really truly ultimately can't understand or relate to, right? So that's something that I think about as a white therapist. If I'm working with a client who's a person of color, right, that's something that I have to be mindful and aware of, right? And how my you know, the power differential, right, that exists, even though it shouldn't, right? But it does. And I have to be aware of that, because how that might influence the way that a client perceives me, right? And then lastly, debrief. If you can, always debrief after a crisis or a difficult situation. It is really huge. It's a really huge part of self-care, and it's a really huge part of preventing burnout. And it's a really big part of learning. So for your own well-being, debrief with a supervisor or colleague after a difficult or intense situation. All right. So let's do a couple of scenarios here. So we've got a couple of situations, and with these, not looking for a, you know, response of this is exactly what I would do. More curious to hear about, like, what are some of the different things that you're thinking about? What would be some things that you would want to consider? What would you be, you know, taking into account as you're deciding how you might want to respond? And if you do have some ideas about how you respond, that's great too. But yeah, really kind of interested in your, like, what would be your internal process here. So let's say you're in this situation, you're talking with a client about housing resources. Upon being given a list of options, the client becomes upset and states she's already tried all of those avenues with no success. She becomes tearful and begins to breathe more heavily and raise her voice, saying no one will help her and that the systems that she's involved in treat her unfairly. So what are some of the things that you might be thinking about? What would you be taking into consideration in this situation? And anyone can speak up or use the chat. We'll just see what a few people say.
Just like, sorry, my neighbor's mowing the lawn. Knowing that the whole housing situation can be really frustrating, I think that would be hard to not to validate without being like, oh my God, I hear you. Like, yeah, it sucks. But
Yeah.
so to kind of process that.
Yes. Yep. Definitely. Yeah. I think some validation would be really important here, right? To just acknowledge, like, yes, it is there. There are limited resources, and I'm really sorry that, like, we can look at some other ones, and yes, I just want to acknowledge this is really hard. I'm sorry that you haven't had any success with these so far. Yeah. Yes. Yep. Some other people have also said validation. Yeah. Just how much of a struggle it is.
I
Yeah,
think that most of the time you just probably have to like admit, like, okay, I get the validation part, but then you also go, don't give up, you know? This is only one part of a big situation that you gotta handle. I mean, so sometimes you gotta think outside the box. Let's think together what we can do. So come up with other solutions to that may not be on the table, other ideas.
Yep.
With encouragement.
Yes. Yep. I just want to say I really appreciate that you came off mute to say that, because just your tone as you were saying that, like, right, and you acknowledged, yes, the validation piece, and then even what you said after that, it just sounded really genuine, right? And that's, like, we've talked a lot in this presentation about nonverbals and paraverbals, right? So not just what we're saying, but how we're saying it. And there was just, I could just hear a lot of encouragement in your voice, but it sounded genuine, right? It didn't sound pushy. It didn't sound invalidating. And it sounded like there was, like, a little bit of, like, I don't know, I feel like I even got the feeling of, like, I will try to figure this out with you.
Right. Thank you. Yeah. It's almost, I do it all day long. I work for the Jeremiah program, and then I work for Tubman. It is really about encouragement to, like, keep moving, keep going, don't give up, whatever that looks like. Because that's basically what you have to do.
Right. Yeah. I appreciate that. Thanks, Danita. Yeah. So, and then some other people, a lot of people talked about validating, and then also letting the client know you're there to support them and continue to try to find resources. Yep. Continue to problem solve and explore options. Regulate first. Sabina said regulate first. Absolutely. Yep. Because there's some dysregulation here, right? There's an increase in activation. Yep. So there might also be some attending to that could happen first. Yeah. Being present. Yeah. Giving a beat of silence. Yep. While she processes the emotion. I really appreciate that. Yep. I think that's a really great point. Yeah, and then keep giving options, and let's explore how we can work together on this. Yeah. So a lot of you, there's an element of collaboration, right? Like, I'm going to keep working on this with you. Like, let's explore other options. It's a we, right? Yeah. All right, let's go ahead and do the next one. Really, really awesome responses there. Thank you, everyone, for being willing to speak up and chime in the chat. All right, so this one, you are with a small group of children in the child care center. A 4-year-old hits one of the other kids, and when you attempt to intervene and correct this behavior, he yells at you, and then he runs away to hide under a table. So same thing. What's going through your mind here? What are some things you might be thinking about?
Hi, I work with kids. I do this most every day. I think if the child that hit the other one wasn't ready to listen to what I had to say, I would model to the child that he hit with compassion, make sure that child is okay. And then tell the other child, it looks like you're not ready to talk about this. I'm here when you are.
Mm-hmm. Yep. Yeah, so giving some space, but then also letting them know, like, I'm here, right? You're still being present, right? It's not like, oh, you did something wrong. So, no, you're saying we can talk about this when you're ready. Yeah. Yeah, someone else said in the chat to give them time to calm down, but be present. Yeah. Yes, absolutely. Getting down to their level to talk. Yep. Being right. Yeah. Being mindful of that, right? That sensory experience of being towered over versus what it's like when someone comes down to our level. Move slowly when you approach them. Absolutely. Yep. Yep. Give them space, allow them to come to you when they're ready. Yeah. Yep. I think, yeah, right, giving them space, moving slowly, right, these different things, because recognizing that, right, they had a little bit of a flight response, right? They may have interpreted your attempt to intervene and correct the behavior as a threat, right? And so, right, ran away to hide. So I think it is really important to be mindful of moving slowly, getting down on their level. But there also might be a little bit of a need for connection there. So I think the fact that everyone is also saying, like, make sure that they still know that you're there and you're willing to talk about it, right? You're not mad at them. You're not going to hurt them. You're not a threat to them. Trying to convey that in as many ways as possible is really important. Yep. Yep. You want to help them correct and learn. Yep. That is important. And I think in a situation like this, again, operating in a really trauma-informed way, the most important thing first is instilling a sense of safety, right? Or trying to, at least, right? So if we continue to just try to correct, right? Correct, teach, say, you know, that wasn't okay, that could make the situation worse, right? So instead we want to approach first, right? Because again, he's had this flight response. So from there, we want to really try to approach with gentleness, right? Gentleness and try to convey to him that he's safe. Yeah, stay with them, stay quiet, give them time and space to calm down. Yeah, we could also ask that question, kind of like we talked about a few slides ago, like, is there anything that you need? You know, is there anything that I can do for you? We can ask that really gently without being intrusive, right? You know, we could give a little space, get down on his level and just say, you know, if there's anything that you need, I'm here. Yeah. And be aware of possible past trauma and how that might be affecting their responses. Yeah, not only with you, but with the original incident, right? Maybe we didn't see what happened, but maybe something happened, and yeah, there's maybe a reason that he lashed out and hit, right? Some of that's just developmentally appropriate, right? Depending on age, and 4 is not, I don't think, too far off from that. But yes, it's possible that there might also be some trauma history at play too, right? So, all right, nice. Thanks so much, everyone, for your responses. Let's all take a deep breath. It's a lot of information. It's talking about some heavy stuff and imagining some challenging situations. So take a breath. All right. And then I think we've just got some resources on these last few slides. So there's some crisis resources, some different websites and phone numbers, crisis text line. NAMI has a lot of just really good information, additional information on mental health if you're interested. The Trevor Project is a really good LGBTQ resource. And then on the last slide, we've got these are just some book suggestions if anyone is interested. That's something that's been asked in the past. So we threw that on here in case anyone is interested. A lot of them are all of them are very trauma focused. Body Keeps the Score, probably one of the most well-known body oriented trauma texts. And My Grandmother's Hands is by a local author actually on racialized trauma, with also a really big focus on how it impacts the body. Healing the Fragmented Selves of Trauma Survivors. Just a really, this one's a really nice read, like down to earth, easy to read, and just some really good information on how people are impacted by trauma, and pulls in some information from sensory motor psychotherapy as well as internal family systems, which are both trauma therapies. And then lastly, In the Realm of Hungry Ghosts by Gabor Mate is a really, really good, he's amazing. He also has tons of talks and interviews and has done tons of podcast interviews. If you're interested, he does a lot of work on trauma, attachment, addiction. That's what this book is, the link between trauma, attachment, and addiction. And he's also done a lot of work on ADHD, as well as how trauma impacts our physical health. So really good person to look into if you're interested. So yeah. And that's that. So, and that's my dog. So just because who doesn't love, you know, a cute picture of a dog. So obviously I'm biased, but I think he's very cute. So that's it. That's what we've got. Thank you all. Thanks for being here and for participating as much as you did. So.